Hey y'all, we're going to try something a little different. I'm going to record this lecture within the PowerPoints for you so you can take your notes as you go along. Each time you click for the slide to change, hit enter one more time and the audio will automatically play. I want you guys to take good notes and we're going to have some good activities when we get to class. Substance use disorder and alcohol use disorder, we used to just call it substance abuse and alcohol abuse. Um, it's a very complex issue. You have to take a holistic approach when caring for these clients because, like the PowerPoint says, it's a cluster of cognitive, behavior, and physiological symptoms. So you have to treat all three. Normally, we're just concerned on the physiological part and the withdrawal symptoms or the negative effects it has on the body, but this we have to take a holistic approach. In regards for those people who are at higher risk, it gives us a few indications. If you had parents who use drugs or alcohol, psychiatric disorders, live in areas of poverty or violence, have easy access to the substance. So when we look at these individually, especially when we have parents, it's more so of an environmental issue and a nature versus nurture. Well, I saw my mom smoke, so I smoke. Well, my dad drink, so I drink. They tend to start doing these things a lot younger, starting at a younger age as well. For the psychiatric disorders, think of it as more so the person is trying to self-medicate for whatever it is, whether it's depression, schizophrenia, whatever it is, they're self-medicating to numb the pain, to dull the voices. Live in areas of poverty and violence and have easy access to substances, I think those two can go together, especially when we're talking about the street drugs, not so much the prescription drugs when it comes to the poverty and violence. And we go to these less loved communities and we can see the symptoms of it. You see the people on the street, you hear the crime rate. It's they go together like peanut butter and jelly, basically. Now, have easy access to substances. It could be that you live in a less loved neighborhood where this stuff is sold on a regular basis. Or it could be that you have someone in your household who have prescriptions and that the people actually don't keep up with them. So you'll hear how children are stealing grandma's meds or the kids got into mom's meds. A few years ago, they had it to where you couldn't even buy like cough syrup and certain medications together without an ID. And then they had to like write all your information down and keep track because they thought people were buying over the counter stuff and using over the counter stuff to create meth, which they were. But either way, easy access to substances, it definitely increases the risk. All right, y'all, for this slide, for each one of these, I want you to define them and also give me an example of each. I want you to be able to tell me and describe to me what each one of these means and give me a scenario when we meet in class. So, as a nurse, you guys are going to be exposed to different patients with different types of substance use disorder, and therefore they're going to present differently and they're also going to have different withdrawal symptoms. So, you're going to need to familiarize yourself with that. And there is a beautiful table within the chapter breaking them each down and giving you good descriptions. The substances we're focusing on for this chapter is alcohol, opioids, CNS stimulants or uppers, and CNS depressants or downers. Also cannabis and hallucinogens, okay? You're going to need to know the physical, behavioral, and the psychological signs for each of those. Now, when we talk about denial and rationalization, we're talking about the common defense mechanisms. So, denial, ignoring reality and refusing to be swayed. So, you go and you tell them, hey, bro, you need to stop drinking. You have a problem. I don't have a problem. You crazy. I don't know what you're talking about. That's denial. Versus rationalization is justifying a behavior or action by making an excuse or an explanation. Bro, you need to stop drinking. What you talking about? I'm fine. I only drink when I get off work. Ain't like I'm hurting nobody. I just do it to relax. It helps me sleep at night. Okay? Know the difference. Now, for legal and ethical considerations, substance abuse among healthcare workers, I want you to take time. It's just one of those cute little blue boxes. And I gave you the page number. I want you to read that, and we're going to talk about that when we come to class. I want to know your opinions, and if any of you who actually work in healthcare have experienced anything like that with your coworkers. This is very noteworthy. So, the effects of substance use disorder on family and friends, it takes a toll. It takes a toll on the person's loved ones. Speaking from experience, growing up in a household with a parent who suffered from substance use disorder, it was very hard on me and my younger niece. Um, After studying, trying to get ready for this lecture, I had an epiphany that I was, me and her had a codependent relationship, me and my mother. Your book describes codependency as another behavior that occurs in circumstances of substance abuse where a person overcompensates and tries to fix the situation or to control the person who uses substances. So it wasn't so much that I tried to fix her. I would overcompensate and make sure where everything was going wrong, it was fixed. So I made sure the house was clean. I would make sure that my niece got on the bus. I made sure we both got dressed for school. I made sure if there was food in the house that we ate. Um, in regards to enabling, my grandfather was the enabler. Whenever she would get in trouble, she'd lose her job, he would pay the bills, make sure we had groceries. If she got locked up, he would go bond her out. And she never really was able to experience the full negative consequences or negative effects or consequences of her actions. And that just made it last so long. All right, so now we're going to focus on alcohol use disorder. Although it's separate on the table that I told you guys to study, it is considered a central nervous system depressant. Okay, so keep that in mind. There are several health complications that come with alcohol use disorder, such as cirrhosis, cardiomyopathy, GI bleeding, pancreatitis, hypertension, stroke, malnourishment, and we'll talk a little bit more about that, sleep disturbances, peripheral neuropathies, cognitive impairment, leukopenia, thrombocytopenia, and chronic infections. It's also associated with, car accidents, and it also has a connection with domestic violence, whether it be abuse of children or spousal or intimate partner abuse. It's become such an issue, Joint Commission requires an admission screening for substance use and alcohol use in the past 12 months. You have to ask the client the type of alcohol, how much, how often they drink, and if they ever experience any problems with using or if they have any problems with going without, okay? This is very important, especially when they're being admitted. If they are suffering from alcohol use disorder, over a several day period, they can start going through withdrawals. And it's easier for the healthcare provider and the nursing team to provide safe care if we know this in advance, because then we know to monitor and to prepare for treatment. Okay? Polysubstance abuse, that's when you're mixing either multiple drugs or substances or a drug and alcohol. Okay. Now, your early symptoms of intoxication is something that you really need to know. So, the early symptoms include drowsiness, slurred speech, loss of coordination, loss of inhibition, turn up, euphoria, everything is so good, and mild impairment of judgment. I think that's where that abuse comes in, gets higher, and especially the traffic accidents. Okay. Excessive ingestion that can indicate alcohol poisoning include mental confusion or stupor. Okay, that's different from the drowsiness. Inability to be aroused, coma seizures, slow or irregular breathing, hypothermia, and bluing of the skin. That is a medical emergency. Okay. Now, when we're talking about alcohol withdrawal, it occurs when a person with a physical dependence on alcohol stops drinking. So I'm not talking about someone who's just, oh, on the weekends I'll have a couple drinks, or at the holidays, I have to have my Baileys with my alcohol. No, I'm talking about those people who, when they get up in the morning, the first thing they need is an alcoholic drink. That is what I'm talking about. Early symptoms of withdrawal takes about, you'll see it within 6 to 12 hours of the last drink. That's why we have to do the screening, okay? The symptoms include anxiety, irritability, and agitation, okay? Progressive symptoms, now mind you, I said progressive symptoms include increased blood pressure and pulse, tremors, nausea and vomiting, diaphoresis, and I don't mean just a little sweat. I mean they're in pools of sweat. Delirium tremens, hallucinations, and seizures. Major withdrawal symptoms can occur 2 to 3 days after the last drink and may last for 3 to 5 days. Now, this is very important. You guys have to remember this. So if you have a patient admitted to you on a Monday and they say, oh, I had a drink right before I came in, you have 6 to 12 hours. So within this shift or the next shift, they'll start to have those mild irritability, um, the agitation, the anxiety. Okay. As it progresses, you will see blood pressure changes, pulse changes. You'll even see the hand shaking, the tremor. Not the asterixis, not the flapping of the wrist, just a little shaky hands. Okay. At this point, that's when the doctors need to get involved, and we have treatment plans put in place. They have medications to help with the anxiety, and they also have medication to help with the symptoms of the withdrawal. You'll see them on Librium, clonidine sometimes if the blood pressure raises too high. And if it gets to the point where we're in DTs or delirium tremens, we admit them to the emergency room, not the emergency room, to the ICU, because then they have to be sedated and treated. Okay. This is very noteworthy. I would spend some time to learn this. So, treatment is broken down into two phases. The initial phase is when they're actually starting to display those progressive symptoms that we were talking about. So, priority is to stabilize the patient and then to detoxify. Okay, so I know you heard of patients going through detox. That's just ridding the body of substances that's causing harmful ill effects. Okay. After the patient is stabilized and, confronting the patient's denial and encouraging self diagnosis, we go on to the second phase. I like to think of it as the recovery, the beginning of recovery, and it encourages group therapy and behavioral therapy. And I want you guys to know the difference. Group therapy helps break through denial and gives the patient a new sense of belonging and identity, whereas behavioral therapy helps with self discipline and discourages impulsive behaviors. I want you to think on those two things and tell me if you think that one is better than the other, or if the client would benefit if they had both. We're all familiar with AA, Alcoholic Anonymous, and referrals to a 12-step program is also a very, very key part of their recovery. Okay, now we're getting into the malnourishment part of the symptoms of alcohol use disorder. Both of these symptoms or syndromes, involve thiamine deficiency. Wernicke's encephalopathy is life-threatening, but it is reversible. Okay, and some of the signs and symptoms are as followed: with the confusion, the gait ataxia, abnormal involuntary eye movements. That's a severe case, okay, but it is reversible. The Korsakoff syndrome, irreversible. Once we've gone that far, it's nothing else we can do. Okay, they have grossly impaired memory and gait disturbances. Confabulation, large doses of thiamine are required, okay, and abstaining from alcohol. Now, I know there's already a pretty table on page 1115 for these, but I want you guys to make your own visual aid. It can be flashcards, it can be concept maps, it could be another table in a way that looks more pleasing to your eye, but I want you to take that information and make it into a visual aid or a study tool and bring it to class. For benzodiazepines and opioids, I want you guys to know the side effects, symptoms of withdrawal, appropriate treatment plans, and effects of overdose. Now, when we think of stimulant use, remember I told you those are your uppers. So think everything goes up. So the pulse rate goes up. The blood pressure goes up. They're easily excited, okay? Seizure activity, because now the threshold has changed and they can easily go into seizures. They have hyperactive reflexes, okay? Cardiac symptoms include dysrhythmias. Their temperature goes up, so they experience hyperthermia. The only thing that tends to go down is the appetite. Now, there's three common categories of stimulants: amphetamines, cocaine, and bath salts. Okay? For nicotine use, I want you guys to make a table of nicotine replacement therapy, the different types, and some of the names, the generic names and the brand names, and how they're supposed to help the person who's trying to quit nicotine. How would you guys approach a client who expresses they want to quit nicotine versus one who does not want to quit nicotine? Both of them need to, but only one is willing and ready. How would you approach that? How would you apply the 5A approach to the person who actually wants to quit? So how would you go about asking about tobacco use advised to quit?